Thank you, Senior. Hello, everybody. Is everybody looking very serious? Can everybody give me a smile, please? Thank you. Smile does not always come very easy, does it? Senior, you can also see me, right?
Yes, sir. We can.
Thank you. Can I start with a question to everyone? How many people are here? 14. Oh, what's supposed to be the number of participants, Senior?
Around 25, sir.
Okay.
Some of them are joining us lately.
Yeah, but we are not doing very well if only 15 out of 25 or 15, less than 15, because 15 includes you and me.
Yes, sir.
Are joining. Obviously, we are not making the course attractive enough to the participants. We like to go into this. Where are we going wrong? So, friends, for those who have joined, thank you very much for being here. I'm starting with this question. Who do you don't have to answer the question now, answer it to yourself. Who all do you respect? As an individual, who all get your respect? I'll wait for a few seconds for you to organize your thoughts in your mind. So I suppose you have found some answers. It will be interesting. If we had the time, I would have asked those who wanted to share so that we would all know. But you have some answers in you. Now, I ask you, can you think of anyone who does not have some qualities, some positive qualities that you do not have? 15 participants are here. I don't know most of you. But one thing I know, that every one of you has some quality that I do not have. Maybe you are braver. Maybe, very likely, almost everyone here will be more intelligent than me. You may dance, you may sing, you may paint like anything. You may have some abilities. You may be good at maintaining relationships. I do not have to know this. But the very fact that every one of you is likely to have something that I do not have makes me convinced that everyone else deserves my respect. This is one point that I wanted to start with. Senior, you too, of course. I don't have to say this. Yes. It would be good to give this some thought, because I want you also to think, do your patients get your respect? Some of them may be quarrelsome. Some of them may not be grateful at all, always shouting at the nurses. Some of them may be wife beaters. Some of them may be even harming children. Please bear in mind that they may still have some quality that you do not have. I cannot always find it easy to respect everyone I meet. There may be some exceptions, but if there are exceptions, that is my fault. I start with this because, oh, Mahima says my audio is too low. Senior, do you also find that?
No, sir, I can hear you well.
So Mahima, maybe you need to adjust your speaker. Anyway, for Mahima, in case she is finding it harder, I make this a bit more. Okay. So why I say this is, we are talking about ethics. Presently, we'll go to the basic fundamental principle, official principles of medical ethics. But before that, I wanted to say that giving the person respect is fundamental to establishing a good relationship. Your ability and my ability to improve the well-being of our patients as healthcare providers depends on the relationship that we establish with each patient. Unless they open their hearts to us, we are unable to help them adequately. And so, friends, please let us remember this one point that I'll start with. Oh, Senior, I'm trying to share my screen. And I seem to be running into a problem strangely. Yes, I think that should be okay now.
Okay, sir.
Senior, visible enough?
Yes, sir, good to go.
Before I go to the official definition of elements of medical ethics, I'll mention these. We will have respect for patients, as being respectful to patients, non-judgmental approach, whether he is a wife beater or whether he harms children is not my concern. It is not my concern. I am not a judge. I am here as a healthcare provider. If he is a wife beater, if he is somebody who harms children, I will remember that there will be very few people who care for him or her, right? Monica, do you agree? Saloni? You must be having patients like that. Rekha, Mahima, Vaishnavi, Shiba. You all must be having patients who are not nice patients. Maybe you will consider them not nice human beings at all. But they deserve my care even more because others may not care for him or her. And I will always maintain confidentiality. What he or she tells me is between us. And when I provide care, however, whatever I may think about the person, however poor she is, however abandoned she is or not, this person will be the focus of my care. The family comes close behind, true, but this person is the focus. And when you deal with them with respect, non-judgmental approach, confidentiality, and provide patient-centered care, we are able to give them a life with dignity, because they are sometimes at our mercy when they are very ill. Friends, any comments about that? Please put it upon the chat box if you have a comment. I'm slightly discouraged because almost everybody's video is off. I cannot see everybody, and I do not see any facial reactions. I do not know if people are hearing me. I do not know if people are able to understand me. Okay, Pooja is in OPD, attending OPD. I understand, Pooja. That's the way life is. Sorry for you. Senior, is
Sir.
something wrong with me, Senior? I'm sure people must have been very interactive at other sessions. Thank you, Rekha. I know you are hearing. I'm also hoping for some reaction. So these are the official principles of medical ethics. Now, Senior, let me ask you one more question, then I'll continue with this.
Oh,
Have
sure,
the
sir.
audience been asked to switch on their videos in advance?
Yes, sir. We are asked to them. Some of them is having network issues.
And that I can understand, but when out of 15 participants, practically nobody has a video on, that I find it difficult to understand.
I have
And
already informed them.
your terms of engagement does not specify that.
Sure, sir. I already updated in group to turn on their videos. I don't know why they are.
So it will be more or less mechanical now. You will, to me, this is like a radio talk. I keep on talking. I don't know if somebody is listening. I know you said you can hear it. I don't know if you are understanding it. I don't know what you feel about it. Okay, I will have to accept that if that's your decision. So these are the four fundamental principles of medical ethics. One is autonomy, one is beneficence, non-malfeasance, and justice. I'll talk about each one of these. But first, sentence each about each. Autonomy is one's right over oneself. This is my body. I have more right over my own life than anybody else. And you may be a nurse, somebody else may be a doctor, you may be a policeman, but nobody has more right over this body than myself. Therefore, whatever you do has to be with my consent. Informed consent. Just asking for that consent in the form when they come in, it's not enough. I should know what you are going to do to me, and you should have my consent. Second, beneficence. Whatever you do should be for my benefit. Of course, is that taken for granted? Well, anything that we do may have side effects. There may be some harm done, but your aim is for non-malfeasance or not doing harm. And this need not be about major procedures. Suppose you are giving the person an enema and you do not bolt the door. Somebody comes and barges in. You are offending the patient's dignity, right? The enema may be successful. Your procedure may be successful by your objective, but we have caused harm to the person by not preserving that, respecting that person, by not respecting that person's dignity and confidentiality. So autonomy, right over oneself, beneficence, doing good, non-malfeasance, not doing harm, and justice, fair allocation of available resources. Fair allocation of available resources, including your time. That doesn't mean equality, it means equity. If there are 10 patients, they do not get your time equally, or they do not get other facilities equally. Those who need more, get more. That's equity. Okay, any comments? Right over oneself, doing good, not causing harm, distributive justice or equitable distribution of available resources. Now I will give you a question. She has been, imagine this poor lady in a village. She had gone to the cancer hospital. She was advised radiotherapy. And she says, I do not want to talk about my disease. Just tell me what to do. No, I don't want you to explain anything. Whatever you say, I will do. Tell me what to do. Now, you believe in autonomy. You know that this woman has a right over her own life. She should take decisions herself. So you are saying there is this possibility, we can give you radiation. It may give you some vomiting, maybe some diarrhea, some pain in the abdomen, but it will shrink your tumor. Would you like to go ahead with this? She says, you decide, tell me what to do. No, she is refusing to exert her autonomy. What will you do? Will you say, no, you have to decide. I am not here to take decisions for you. I respect your autonomy, you decide. Will that be the right approach? Senior, will you administer this poll? There are
Yes,
three
sir.
choices given. One is respect her autonomy, and she doesn't want to talk. Don't tell her anything. Just write a reference letter to oncology. Second, tell her you must know. You have to know about your disease and take a decision. Or any other response. Please respond to the poll.
Okay. Please select the choice that you feel is the most appropriate.
And then click on it, I suppose. Maybe
yes.
that has to be clear. So the 4 people have chosen the third option. If your choice is a response is something else, please write it down on the chat box.
So we have a comment from Salam.
I'll wait a minute. So there are 17 people in the room, and 12 people have responded. Thank you very much. We are still missing several people, but the majority are opting for some other choice. But is it right that only Salome has responded?
Yes, sir. Only Salome responded in the chat. And Shiba also.
Salome says, trying to explain that some of the therapies might be challenging. We don't want to decide over her head. So you are practically, Salome, going by item 2. It's important. You have to decide. And what was the other chat? Shibas, will you please read it out for me? Senior,
Sir, I can read it out.
please.
Where we can talk about her disease condition when she is acceptable.
So that's again more or less 2, right? Wait till she is ready and still tell her. Okay, thank you. Now,
2 more responses, sir.
yeah.
From Saloni, like, sir, we try to tell her about the treatment and tell her however it
Yes,
is.
very good.
And Monica says, ask her about her feeling or any problem she have that she don't want us to know.
Okay.
And
Okay.
Meenakshi says professional counseling. Thank you, sir.
What is this professional counseling mean, actually? For every person who is, that's great, wonderful.
Yes.
Is that something that will be available in the majority of hospitals? Meenakshi, where are you from?
I'm from CMC Ludhiana, sir.
Yeah, maybe you have that kind of facility, but most of us find that we, in such situations, we have to handle them ourselves. We have medical social workers who are rather skilled in counseling, but here the problem is the counselor has also, it's necessary to understand the disease and understand the treatment, and therefore a teamwork will be necessary. It's great if we can give that kind of support. I totally agree. It's also true that most of the time that may not be possible. So let us see whether it's a professional counselor or one of us ourselves dealing with it. What we need to do is to go for ideally shared decision making. As many of you have commented, make a relationship. See, our Dr. Amrita is here sitting down with the patient at her level, not standing and talking down at her. A hand on her, on the patient, conveying with the eyes and face that I care for you, asking, how can I help you? Let us work together. So as many of you have mentioned, that is at the essence of it. The more information given, the better. And when they say, I don't know, sister, I don't know what to do, you tell me what to do, I will obey that. If that is there, then at some point of time, after giving her enough time, if she still says that, maybe at this time, you will have to help her. You are not still taking a decision, but you may tell her, if Didi, if I were in your position, I think I would go for the radiation. We will help you to cope with the symptoms. That's what we might say. I hope that's what you will tell me if I am your patient. But then she is hesitating, and would you ask for a written informed consent? If you want to give her morphine, is it necessary? Exercising autonomy means they have to agree to everything. So I tell her, we are going to give this tablet morphine for your pain. Would you like to give it in writing? No. The answer is no. If somebody is coming to a hospital, it's implied that the necessary medications will be given. For each and everyone asking for a consent is confusing to the patient. This woman in her whole lifetime would not have had to affix her signature to a document more than 5 times in her life. And that's a momentous thing. What am I signing? She'll be scared sometimes. So implied consent is there for administration of ordinary medicines. But if you are doing an intervention, then consent is necessary. I'm giving you another poll, a bit more difficult decision. And she is having advanced cancer, is now breathless, unable to breathe properly. A specialist doctor comes and sees and says, move her to intensive care. Her oxygen saturation is too low. The woman says, no, don't take me to ICU. Her son says, take her, whatever do you want to do, doctor? We want the best care for her. If she needs ICU, give her ICU. What will you do? Senior,
Yes,
poll,
sir.
please.
Sure, sure.
Will you respect the patient's autonomy and not take her to ICU? It's her choice, her decision. Or will you follow the son's advice?
So the second ball is here. Please click on the most appropriate answer that you think is appropriate. So we have a comment in the chat from Monica.
Senior, wait for 10 seconds more.
Sure, sure.
Okay. Majority of people respect her autonomy and would not take her to ICU. The son is now getting angry. He's shouting at you. You said she needs intensive care and you are not doing anything. What kind of people are you? Don't you care for my mother? We have a problem here very clearly. Monica, thank you for your comment. Remember, what's our objective? She has advanced cancer. That's clear there. It is not likely, she is not likely to recover. What we really would like is for her to be as comfortable as possible, physically, emotionally, socially, spiritually. She doesn't want the isolation in ICU. In her position, I would not want it. I know that most hospitals do it, but I do not want it. That touch, a glass, a little bit of water to sip from the daughter with a hand on the forehead, that is the most precious thing for her. Not the silly machines, which will only prolong her dying process and worsen her agony. True. But here, it is really true that in the real life, people really go by what the son says because they are scared. So instead of choosing one or two, let us think of other possibilities. One, oh, not this one. The recommendation of the National Cancer Grid, which is a collaborative of more than 200 cancer institutions in the country, in India, together have formed this document. I have given the link here. Senior can give you the presentation so that you can all see this. 10 low value or harmful practices that should be avoided in cancer care. Do not treat patients with advanced metastatic cancer in ICUs unless there is an acutely reversible event. The woman doesn't want it. The National Cancer Grid says it is bad practice to put people in ICU, but so many hospitals do it. The family members would persuade you to do it. This is a challenge. Again, this is shared decision-making process is the answer. It's not just an yes or no from the son. Okay, she is still in the ward. And say, okay, we'll start oxygen here. Let us talk. Start her or put her on oxygen. Take the son to a side room. Sit down with him. And what would you say? Why does the son want her to have an ICU? Because she loves you. He loves her, right? Acknowledge that. Faisal, I see that you love your mom so much. Respect for that love. We want to help you and help her as much as we can. There are a few things that I want you to understand. But first tell me, what do you think is happening to your mother? What do you think about her chances of getting cured? And then give him all the information. But yeah, we do not have to take a decision right at this moment. Take some time. Go outside and take some time to think. You love her so much that you want to remain her alive for a few more days. Is that more important? Or is it more important that she should have a comfortable time with you, sitting with you, holding your hand? Help the man to take a decision. ICU should not be given like a waiter gives a menu card. Hey, she needs it. Shall we take her to ICU? It's horrible. Sit down with them. Till you have taken a decision, do whatever you are doing. Don't escalate it. Give him time and arrive at a consensus. After some time, if we are supporting, it's most likely that the son will understand. I know that it doesn't always work, but our objective is shared decision making, the patient coming first, but also the son and you. Any comments about that? I'll accept it doesn't always work. You cannot win all the time. This is what I would try to do. First, you and I have to think about what's our duty of care. This is how the Indian Council of Medical Research bioethics unit defines it. Look at this. The healthcare provider's duty of care is to mitigate suffering. It is to cure sometimes, relieve often, and to comfort always. There exists no exception to this rule. Mitigate suffering. This photograph, which appears on the cover of the Lancet document, ICMR document, was taken about 2 weeks before she died. She was in agonizing pain, but palliative care enabled her to sit up, have some food, play with the children, and have that smile on her face. That is our duty. Mitigate suffering. Cure sometimes, relieve often, comfort always. When cure is not possible, relieve distress, comfort always. There exists no exception to this rule. So, to the earlier poll question, my answer is, I gave you only 2 choices. It was unfair of me. Neither is the choice. The choice is to sit down and have that conversation. And as who said that, Monica? If there is a professional counselor working with the nurse and the doctor and getting all the facts and helping them, that's great. I fear that not even 0.1% of people in our country would have that privilege. It happens. It happens in some particularly expensive hospitals, but not ordinarily. So this would be the sequence. We have to think of what is a doctor's perception of duty of care. We are not only talking about ethics here, we are also talking about end of life. And I hope one of you will look after me when my time comes. Remember, your duty of care is to relieve my suffering. There will be challenges. If you don't understand this, you will be trying to put me on a ventilator and keep my heart beating. My family's attitude out of love, they may inflict suffering for me. You have to help them understand. The relatives also will come and say, why are you not moving her to ICU? Because she doesn't have money. and there may be legal questions. India does not have a law covering end-of-life care, and therefore, people very often talk about euthanasia more than end-of-life. I am mentioning this because in every discussion on end-of-life care, this point comes up. What's the point of me being alive? Can you kill me? Just put in something nobody need to know. Right at the moment our inpatient ward has a patient who was begging to his wife 3 weeks back to help him to die. She did not. And yesterday he was smiling and enjoying a cup of fruit juice. You should not, anyway, we are not talking about euthanasia. I know this will come up in your mind and I am answering this question. If somebody asks me this, they do. Every year a few people come to us asking to be killed. And what I'll remember, what is the issue behind the question? Why is she asking to be killed? Is it because she is in pain? I would relieve her pain. Is it because she has been abandoned by her family? We will have to be her family. She has asked for euthanasia, and if I respected her autonomy completely, I should be giving it. But I will not. I give her a pain relief. And I'll make this statement. In the vast majority of patients, palliative care is the viable alternative to euthanasia. In a minority of people where you fail to improve quality of life, balance the individual's interest with the society's view and the law. Even if she insists, 9 out of 10 people who come begging for euthanasia sit up and smile the next day. But once in a way, there will be somebody whose quality of life you cannot improve to their expectation. Unfortunately, we cannot respect their autonomy and kill them because in India, law does not permit it. In India, euthanasia legally is murder. We should be, as far as possible, allowing them to stay with the family. In your care, it will be aimed more at comfort than anything else. If she is unconscious, if she is semi-conscious in the last days, having severe pain on movement, instead of changing her position every 2 hours, you may decide to take a bit longer when she is dying. Use an airbed so that you don't have to move her every 2 hours. Aim for the comfort. Remember that the emotion family is suffering along with the patient. This so-called bystander is a hugely suffering person, and her needs also we will have to take care of. And particularly remember children in the family. If there are 17 participants here, I am sure 1 or 2 must have experienced the distress of a loved person dying when you were a child, a grandparent maybe. And those of you will remember how much children suffer. Unnecessary fears. Grandpa died. Is that what happens to people? Will dad also die? Will mom also die? Who will be there for me? These questions are there in the minds of children. They also need explanations. If she is a religious person and desires to see a priest or a religious person, we have to facilitate it. It's her life. End of life care nursing. Every point I cannot reach you. I am not a nurse. I am not adequately empowered. But this I know, that turning the person's position, looking after the skin, looking after the mouth, they are all important. Mouth care is very important, yes. Caring for the bowels and the bladder, they are important, but that's not enough. You are in the position of being able to do most for me. When I am dying, the doctors will come every day and go. Even if that professional counselor comes, he or she will have 1 hour to give me. But you people will be there throughout the day and throughout the night. You will have the time. Sit down with me. Ask me, who am I? What are the elements of my suffering? And then you will find that I have a lot of questions in me, and you may have to answer that question. I'll end with this statement, which essentially asks us, you and I, all healthcare providers, to get to know the patient as a person. Treating a patient's severe arthritis and not knowing his or her core identity as a musician, providing care to a woman with metastatic breast cancer and not knowing that she is the sole carer of 2 young children, attempting to support a dying patient and not knowing that he or she is devoutly religious. Each of these scenarios is equivalent to attempting to operate in the dark. When I am there on my deathbed, if you are looking after me, remember whatever senior told you about my introduction doesn't really describe me as a person. You sit down beside me and find out what is the most important for me. And I may tell you reluctantly, can I talk to my son once more on the phone? He cannot get here. I think I will not live to see him again. And facilitating that phone call at that time, maybe a video call, maybe the best end of life care that you can do. So friends, I have mentioned, I started by, I'm hoping that there will be an active discussion. We will have time for at least 10 minutes for discussion. But before that, the important points that I mentioned today are one, that before I go to the official elements of medical ethics, I went into some points like giving respect, treating the person with respect, respecting confidentiality, ensuring dignity, approach being non-judgmental. And then I went on to the 4 fundamental principles of medical ethics. I mentioned autonomy, but autonomy is, that is, patient's right over himself or herself, but that's not to be practiced blindly. Get to know the person, practice shared decision making, do the best for the patient, try not to do harm. Of course, you will have to distribute your time and other resources equitably, but essentially, let us aim for shared decision making. She needs your help to take decisions and my help. Let us make that happen along with the family. We also mentioned that at the end of life, in incurable illnesses, generally, intensive care is not a good place to be in. Children may force the mother or the father, but we have to sit down with them and help them to understand. There are 2 kinds of love. This is true for all of us.
देख मेरी भी क्लास जेड में चल रही थी।
Sia, will you mute your microphone? Instead, put a switch on your video. So what was I saying? When Sia started scolding her child, what was I saying? I had finished up. At that time, the most important thing for the person is what we'll try to do, which may not be a machine and a tube in the throat and a ventilator. The most important thing may be a yes, maybe most important thing may be a loving touch, conveying that you care for the person, and that may be the most important things. Sia switched on her video. Thank you very much, Sia. Just to prove that she was not scolding any children, but just quarreling between the two of them. So, and then we went on briefly to the issue of euthanasia. Some countries have the mercy killing. Some countries have legalized euthanasia, like Switzerland, some states in the USA, Netherlands, Belgium, Germany, Canada. There you can opt for assisted suicide or euthanasia, but not in most of our countries. It is illegal. Even the person wants it. Instead, if someone begs for euthanasia, you look for what is the reason. Why are they asking for it? They must be asking for it because their life is unbearable for them. It may be pain or breathlessness. Let us treat that and make life comfortable if necessary, even with sedation. It may be because they are not getting love and affection, which is what we will provide. And finally, I ended with that quote from Dr. Harvey Chochinov. The most important thing is to get to know the person, understand the person, and give the person treatment with love, with dignity. Thank you. Now we do have some time for questions and answers. To everybody who switched on the video, Meenakshi, thank you, Sia and Manisha, and everybody who switched the video on. Almost everybody, this is phenomenal. I can see you interact with you as human beings, not as dark shadows in the screen. In between, several people must have disappeared to put on a bit of face powder and a bit of makeup, but you all switched on your videos. Thank you very much. Of course, time for questions. You might ask, either unmute and ask or put it upon the chat box.
Yes, sir. So, but many times, like in our setting, the patient who are with the schemes, means a central government scheme or something, they don't understand the pure meaning of palliative care. They always that keen on give our patient ICU care, ventilate, put our patient on ventilators and all. They never understand this thing that their patient need a comfort. Like the intubation and all these things, it's not going to reverse anything. If we counsel them also, then also they don't agree with that.
Meenakshi, this is a problem, not only for illiterate people. I think generally illiterate people and poor people from the village accept our counseling much better. The problem is most with educated people from the cities who are not ready to think about death. I mentioned people from the villages and poor people because there death is more familiar to them. The sophisticated people of our society are unfamiliar with death in this generation. Meenakshi, there are 2 or 3 things that I'll mention in answer. 1, you cannot always win. 2, the major problem is that this conversation is started too late. The answer is to start the conversation early, not when they are dying, much earlier. When somebody is telling them, you have cancer, in the week following that, the prognosis has to be discussed. We are going to be with you. We'll try our best to achieve cure of your disease. And if the disease becomes incurable, then we are still giving them reassurance. Even if we cannot cure it, we'll treat you with comfort. And at least at that point, raise the question, ask them, have you been able to think about the future? Meenakshi, I'm saying this is not only important for the patient in the ward. This is important for your grandparents, your parents, your relatives. Every single human being has to go through this journey. This is important for all of us. We will go through it in our lives. Unfortunately, I'm sorry to say such inauspicious words, but every human being dies. And we have to be courageous to bring up the question. We are not saying that immediately when you are dying, where do you want to be? Of course, we will not say this. But have you thought about the future? For example, we will try to keep you as well as possible. But if you do get very ill, where would you want to be? Would you want to be treated in a hospital or in your home? Okay, your home is not accessible. We will not be able to relieve your pain. Okay, we will, in that case, put you in the hospital. But in the hospital, where would you like to be? This conversation is not only with that patient, with the family present. You cannot always do it. You do not have the time. But you are spending the time on the last day, spend it early. Of course, Meenakshi, you can't do it alone. Has to be part of a system. I hope, Meenakshi, are you a practicing nurse or are you a nursing educator?
Actually, sir, I'm a physician assistant under medical oncology, sir.
Meenakshi, this is a question to be discussed in the group. Your doctor, the nurses, all together have to discuss end-of-life care. In our country, things are not very good at the moment. But you and I are agents of change. Just as senior is, everyone here is an agent of change. We have to generate that discussion. I'm sure there must be some nursing educators in the group. And particularly to them, the new curriculum has just come in. You know that in 2022, the Indian Nursing Council has included palliative care in the curriculum. The teaching modules are available for free download on our Pallium India website. Please teach, discuss end-of-life care. This is important for everybody, including every single one of us in our lifetime. Meenakshi, are you? I know I did not give you a very clear, precise one-sentence answer. Are there any more questions arising from my answer?
Actually, sir, we for every patient we start explaining from day one. If it is a like stage 4 disease, we never hide anything. Even though we ask so many times from the relative that you want us to explain it to a patient also. If they say yes, you can explain to patient also. We explain to patient also, sir. And from day one, we tell them this is a stage 4 disease. There will be time then when you have to decide whether you go for IC or not. Then there will be chances that the patient, the patient disease will progress, and the patient will not be like same the patient is today. Then I don't know, but most of the time I've seen that the patient who are having funding, who are like we have different funds for patients. So the patient who have funding, they never understand the thing. They say that they don't have to pay, then put our patient in ICU, ventilate the patient and all these things. If we actually, this is very difficult for us also, because this is a medical legal cases. So if we will not put them in the ICU, or the next day they will charge against, they can use all these things against us, sir.
Meenakshi, when you say they never understands, I am concerned. If they nobody ever understands, there's a problem in the way we are communicating with them. They possibly think that you are only trying to save the money for the hospital. Maybe, I mean, senior, is our session on communication over?
Yes, sir, it's over.
Maybe that will have to be taken up again. Say like very often, Meenakshi, it is like a game of tennis. You say, okay, he will not be comfortable in the ICU. The son says, no, save my mom. You don't try to save money. Save my mom. This goes on and on and on. Instead, if you sit down with that son and say, listen, I see that you love your mother very much. And he will talk about the mother. He will say how much he loves her, what all she did for you. And then you are on their side. You are not on the opposite side of the court. You say, we will work together to give the best care for your mom. Always do this. Jump over, then get on his side. Acknowledge his suffering, acknowledge his love, acknowledge her suffering, acknowledge her love. And then get into this partnership. You and I will plan together. These are the things that are likely to happen. Meenakshi, that decision about whether to look after the patient or not in the ICU is not to be brought up on the last day. But if, Meenakshi, in spite of explanation, nobody ever agrees, then we have a problem somewhere that will have to be gone into. Where are we failing with our communication? And maybe there are answers there somewhere. I see that we still have, maybe senior will allow us to take a couple of minutes more for any one more question.
Sure, sir.
Seema, did you raise your hand? No. Okay, senior, then you can move on to the case presentation.
Yes, sir. Today we have a case presentation by Sister Monica. Sister, are you there? Monica, ma'am, you are muted. Please unmute from your end. Monica, you can start now.
Can you hear me now?
Yes, Monica, you also see that you are from Negrims. Hello.
Yes, sir. Yes, sir. I'm from Negrams.
Monica, have we met each other when I came there? Did you and I meet? No.
No, sir.
Oh, okay. Right. Continue.
Good afternoon, sir. Good afternoon, ma'am. Good afternoon, everyone of you. My name is Monica Karputan. I'm a staff nurse working in Negrams, Meghalaya. Today, I'm going to present a case presentation of a 73 years old female diagnosis with CVA with intracranial hemorrhage. Presenting complaints, she was having bed sore over the sacral region, constipation for 5 days, fever on and off. History of illness. Previously, the patient had recovered from stroke twice. In the month of January 2022, the patient fell down at home, followed by one episode of vomiting, and the family members immediately took her to nearby hospital, private, and thereafter was referred to our hospital, and she was admitted in ICU for a duration of 3 months. Patient developed bed sore in the sacral region at home. At present, she is semi-conscious with tracheostomy tube, Ryle's tube, and Foley's catheter. On examination, she is semi-conscious and oriented. Temperature was 98 degrees Fahrenheit, pulse 92 beats per minute, respiration 20 beats per minute, BP was 140 by 80 mm of Hg. Treatment and significant investigation. Her routine examination HB was 14.0, WBC 14.7 into 10, serum urea 65, creatinine 0.6, sodium 143, potassium 5.14, RBC 4.7. During her stay in the hospital, they did CT scan, which shows intraparenchymal hemorrhage is noted in right capsulothalamic region extended into all 4 ventricles. Psychosocial aspect. She is a pensioner. She have 2 daughters and stay with her youngest daughter and grandchildren under one roof. The youngest daughter at present, she has no stable job. The patient had a good relationship with her eldest daughter and declared all her eldest daughter as the rightful heir to her properties. The patient has no healthy relationship with her youngest daughter. The youngest daughter take care of the patient at present. Her medication, she is on tab Levipil 500 mg TDS, tab amlodipine 5 mg OD, tab Pantop 40 mg on empty stomach, tablet cefuroxime 1 tab twice daily after food, tab Calpol SOS, syrup lactulose 2 teaspoons at night, Megahil ointment for bed sore and regular dressing for bed sore and tracheostomy. Main concern is her bed sore, foul smell, fever, and constipation. Summary, a 75-year-old female diagnosed with CVA with intracranial hemorrhage. She is financially stable and she received palliative care. Discussion points. Empowering caregiver and patient's care. What can we do for this patient? Hello, sir, can you hear me, sir?
Yes, yes, we can. I can hear you very well. Can you go to the last slide, previous slide? Just go back on slide. Okay, go down. No, not to the previous one. The last slide, discussion points. Okay. Senior, is there anybody moderating this case presentation?
Actually, no, sir. Shiba ma'am is
Okay.
not available.
Okay. So, friends, here this is not a time for me lecturing. It's a time for all of you to chip in. Here is a patient. Monica, sorry.
Yes, sir.
Who was the one who presented? Monica, right?
Yes, sir, Monica.
Monica, is this patient going to stay in the hospital for a long time, or are there plans to take the patient home?
She was in the ICU, sir, for 3 months. And after that, the doctor have explained to the patient's family member that it will take time for her to improve. And so the family members and the doctor had referred to palliative care. So we have explained to the patient's family that it is better if you take her home in her own bed, so she will be comfortable.
Monica,
Yes, sir.
uh, we generally, our healthcare system provides disease-focused care.
Yes.
She had a stroke, cerebral hemorrhage.
Yes,
It
sir.
got excellent care. She got a scan. If it was possible to improve it, it would have. But I find in any hospital, it is not justifiable for somebody to get a pressure sore. I can understand it if somebody gets it in a hospital, in a home, but in the hospital,
She
this
got it
means she in the ICU.
at home, sir. She got.
Oh, wait a minute. She got a stroke and then she was in the hospital for 3 months, right? ICU.
Yes, sir.
So
They
how
took
come?
her.
I didn't understand. Sorry. Monica, in between, she was taken home
Yes, sir.
for how long?
It's been 2 months, sir.
Oh, okay. Now patient is in at home.
Yes, yes, sir.
Okay. So, sorry, my mistake. So somebody starts saying, speaking about engaging with the caregivers. Empowering caregivers is what Monica has written. Who is going to speak first? Not me, not Monica. Anybody else? What all can we do? Involving family members in care, totally correct, Shikha. What does that mean? How do we? They are looking after the patient, right? She is at home. They are the ones who are involved. Shikha, what do you mean involving them? Do you mean empowering them? Yeah, speak on
Yes, sir.
Shikha.
Teaching family members how to care for bed sores.
Hmm. Okay, Mahima would have you, Monica, call the elder daughter. She got all the money. Salome, explore the family issues. Very good. Sorry, is it Sia speaking? Who is was speaking?
Yeah.
Yes, Sia. What did you say? You are not very clearly audible. Please speak again. Salome, I totally agree. We need to explore the family issues. The patient has given all her property to the elder daughter, but the younger daughter is taking care of her. She has one caregiver. The elder is not taking care of her. You explore it. Okay, there must be some under problems. The elder daughter got all the money. Maybe her family situation does not allow her to look after the mother. Maybe she has a husband who does not allow her to come over and look after her. So many things. We will explore that. Explore that not out of curiosity. Why is the young daughter who is not getting the property looking after her? Not the idle curiosity. But Salome, I totally agree. I'll first sit down with the younger daughter. The patient you said is semi-conscious, may not be in a condition to talk, but I'll sit down with the younger daughter. Salome, shall we make an exercise of this? So you have got the younger daughter away from the patient. You are seated in a side room. You sit down, of course. You are seated there. What will you tell the daughter, or what will you ask?
I think I would ask her the how she sees the situation, how she feels about it. Um, trying to explore if she wants to talk about the situation.
Salome, where are you from?
I'm from Switzerland.
Okay, thank you for being here. Absolutely, Salome. It is about finding out her point of view. Here, I would possibly start by expressing appreciation for the younger daughter. I see that you are looking after your mother practically alone. This must be so hard for you. Just say a word of appreciation and then they will start talking, right, Salome? Simi says, teach them the care of bedridden patient. Listen them carefully, address their concern. Simi, I'll put it the other way. Listen to them first. Salome wanted to explore the issue. The exploration is about asking and listening more than talking. Very often we straight away go into teaching, but we need to understand what is happening. Express appreciation. Make the person feel respected, valued. And then say, this must be a very difficult situation for you. And wait. Allow silence. Silence is very powerful. Say this and be silent. And then the daughter is likely to start talking about the history, about how her mother was partial to the daughter, maybe, or maybe they forced her, we don't know. And how now she feels torn between anger towards the situation and between the need to care for the person. Your appreciation, acknowledgement will be very valuable for her. Instead, Simi, if you just started lecturing her about skincare, pressure sore, etc., she may be less receptive. When you acknowledge the value of what she is doing, when you convey your respect, you already have a partner in the care of the patient. Listen to her, understand her problem, and then forward. Mahima, calling the elder daughter may not be an option at all. It may not be possible. Maybe it is possible. It is very, very unlikely that the elder daughter doesn't know that the mother is ill. Having said that, if the patient says, semi-conscious, on a lucid point says, I want to see her, then maybe you may negotiate for a single visit. You will not be judgmental. That's important. If a daughter doesn't care for the mother, apparently, I will not be judgmental about the daughter. I don't know the background. I don't know what all trauma she has suffered in her childhood. I don't know what all problems she is living with. Salome, thank you for bringing up this point about exploration. And this has given us the opportunity to explain the need to be with the person and being non-judgmental. Listen more than we talk. Yes, Simi, of course, the daughter may say, the younger daughter may say, whatever I do, that bread sore keeps growing. I don't know what to do. Everybody is blaming me. That may be what you say. And then we will work with her. Let us help you. I will work with you. Not by blaming her for the pressure sore, by the expressing appreciation for what she is doing. I'm sure somebody else must be having a comment or a question to Salome. Hello, everyone. Shall we stop the screen share?
Yes, sir.
Salome, would you have written in the chat box, would you like to read it out and share it with everybody?
I think quite often reconciliation is becoming a topic at the end of life, not only for the patient, but for the whole family. They may not realize it themselves really, but we can play a part in helping them to actually see that, and it may work, it may not, but yeah, we can play a part in reconciliation of the family.
Applaud. Absolutely. Hey friends, as many people are not having questions, shall I tell a story? And then Salome can comment on it. I had this patient. Oh, well, he was around 60 and he was dying. And he had two loving children. He had his wife with her. The wife repeatedly used to say one thing: this man never looked after himself. He always worked very hard he was the caretaker at an estate, rubber and things. He never looked after himself. He would never care enough for himself. He did not make money out of this. He was too honest. And what did he gain? The estate owner made a lot of money. Look at him lying here. He has nothing. And this was repeatedly happening. And the man would sit there silent with his head hanging. I created the opportunity to talk to the man alone. And he told me his story. It was quite a story. Growing up as an orphan. Growing up with a stepmother who was not very kind to him. Running away as a teenager. Starting working. Gradually earning enough to buy a small plot of land. Building a house brick by himself. Getting married. He said she was a good woman, but she doesn't understand me. Having the children, feeling very proud that he has given them an education which he did not get. In India today is Guru Purnima day, the day to respect teachers, express respect for teachers, and I would make him one of my teachers, one of my gurus, who taught me about integrity. He had this uneducated, had only primary education. He had several principles. He said, a healthy man has no business to be idle. A thinking man has no business to be dishonest. Healthy man has no business to be idle. Healthy man, thinking man has no business to be dishonest. It was a man. I mean, you could turn it around to a she any day. But these were the principles that this man, uneducated man, lived by. At the end of our conversation, I folded my hand to him and said, I truly have enormous respect for you. Then I had a discussion separately with the family. I listened to the woman. She went on complaining how the man was too honest, did not make any money, etc., etc. After all the conversation, which was facilitated by our social worker, she told him, I see your point of view, but I want you to know that we all have enormous respect for the man. And then she looked at the children and said, I think you are lucky to have a father with so much of integrity. We all admire him. The children cried. The woman sat silently. After a long time of silence, she said, "He is a good man." We made the children talk to him to express appreciation for the care that he gave them, the education that he gave them. They cried together. This is the reconciliation, Salome, that you are talking about. If you are judgmental about the older daughter, you have lost it. You don't know her side of the story. It's very, very, very important to be non-judgmental. Rekha, Shikha, Soni, you are not judges. And I'm telling myself, Rajagopal, you are not a judge. You don't know enough. You do what you can without judging others, without blaming others. And that elder daughter someday might come and they will cry together. The mother will be angry, angry first, then they will hug and cry. And that's the reconciliation that Salome is talking about. And maybe the mother will hug the younger daughter and cry. And maybe she will apologize. And the younger daughter may also apologize. Mom, I have been angry with you some other time. I'm sorry. That's the reconciliation that Salome is talking about. Here, Salome is a course participant, but also one of our teachers. Thank you, Salome. We have 7 minutes more, friends. Hey, you heard the story. You heard the story of that family from Salome. You heard the story of that man from my town, Trivandrum. I'm sure there must be some thoughts that are going through your mind. Share those thoughts with us, please. If you don't want to talk, put it upon the chat box. Yes, no one has a comment. I'm sharing my screen again with that quote of Harvey Churchill. And then I have something to say to every one of you. This is not only about patient care. This is about human relations. I might ask every one of you, Vaishnavi, Shikha, Saloni, Simi, Kanchan, everyone. This could be very much applicable for your day-to-day life, your family life. Do you really know your parents or your grandparents? Oh, you know them, mom, dad. You know that they are loving, they look after you, they educated you. Someday, sit down with them. Say, Mom, tell me about your childhood. Dad, tell me about your childhood. Or you may do it to your grandparents. And then you will find stories that you have never heard. You may have heard some stories. Explore. Salome earlier said explore the feelings and thoughts. Explore and get to know them. You will know then that at the end of 2 conversations, you have bonded more than ever. All this, getting to know somebody is important in all human relations. To your roommate in your hostel, to the extended family, to your spouse, you will find that you do not know him or her well enough. And then finally, I would also say establish that relationship also with the children. Listen to them. Most of the time we are telling them things. Very often we do not listen in it. And I'll find that life becomes more worthwhile when we have that established that kind of relationships. And this is true for not only palliative care, not only for all healthcare, but for all human relations. Any comments, Salome? Salome, in the last couple of minutes that I have, can I ask you a question? Earlier in the session, I mentioned Switzerland as one of the countries where euthanasia is legal. These are only stories for us. In some countries, like Canada in 2018, legalized euthanasia, but they also passed another law making palliative care a right. So I have always believed that before anybody starts talking about euthanasia, we have to make sure that suffering is treated and palliative care has been given. Does that happen in Switzerland?
So I haven't heard that palliative care is a right, but yeah, I think not legally, but anyone in Switzerland can have palliative care. So I wasn't working on a palliative care ward in Switzerland, but on a medical ward, and we were practicing palliative care. We had some schemes and so on. As soon as it was decided this patient is palliative, then we started really practicing palliative care and not curative care anymore. And so, yeah, so palliative care is definitely a big topic already since many years in Switzerland. But in the media, you hear much more about euthanasia than about palliative care.
Yeah. The same in India, although it's illegal. There's hardly any talk about palliative care, but there's a lot of discussion about euthanasia. It happens here also, everywhere. That's more sensational. Everybody, thank you very much. Maybe we need to close the session. Senior,
Sure.
it is time. By all means, close the session. But Salome, I'm curious about what you were saying. Would you have 5 more minutes to talk to me? Senior, you can
yes,
officially close the session.
okay.
But I'm just going to sit here and talk to Salome a little more. I don't mind anybody listening in, that's okay. But Senior, only if you agree to keeping the Zoom on for 5 more minutes.
Sure, sir, you can go.
Okay,
Sure.
thank you. Salome,